Hello, everyone. We will begin in 1 minute.
Okay, Carrie Lynn, do you hear me?
Yes, we do.
You're on live, Linda. Okay.
Hello, everyone, and thank you for joining us on the COVID-19 Industry Town Hall. Today is Friday, April 10th. My name is Carrie Lynn Box, and I am the Senior Manager of Chapter and State Relations for AORN. All attendees have been muted. To ask a question, please type it into the chat box at the bottom of your page. In the event we are not able to respond to all of your questions within the hour provided, we will add them with answers to our aorn.org/partner webpage. I would now like to introduce Maureen Gerard, Vice President of Sales, Medical Products and Solutions. Maureen?
Thank you, Carrie Lynn. Welcome, and thank you for joining the AORN Industry Town Hall. I am Maureen Gerard, and I'm pleased to host this important town hall meeting. COVID-19 has very rapidly introduced a level of change in our work and home environment that we have never experienced. Elective surgery is canceled, operating rooms are closed or transitioned into intensive care units, nurses are redeployed or furloughed. Some hospitals are overwhelmed with patient volume. Other surgery centers stand empty. Delivering surgical care at this time takes a village. Nurses, physicians, caregivers, and the entire frontline team have adapted to the changing COVID-19 patient care demands. And we know you have adapted too. Vendor partners are an important part of the team, delivering supplies and supporting surgery. Thank you for your strong collaboration during this time. We know it's not easy. With this crisis, either your supply chain struggles to keep up with a rapid and unpredictable increase in demand, one that is too fast to respond to, or your business is faced with a steep drop in surgical volume and rapid decline in product demand, resulting in idle resources and capacity. Both situations create obstacles for your business. It is difficult to understand what your customer needs are today and in the future, and how to plan your business moving forward. We know how important it is for you to hear the voice of the customer during the COVID crisis. Understanding what OR nurses and leaders need today will enable you to maintain connections and begin to plan for the future. AORN has a strong connection to operating room nurses and leaders and a portfolio of tools to support your business and our customer during the crisis. During today's town hall, you'll hear from Linda Groh, who will highlight how AORN is responding to the crisis. This includes tools for nurses, leaders, and associations across the industry. Judy Pins will share the results of an extensive AORN survey of nurses and leaders, along with feedback and case studies from surgical leaders at top medical centers across the U.S. in her updates from the front lines. And we're pleased to have Deb Ebert from Memorial Care Health System in the greater LA area, who is living through the COVID crisis and will share how her facility is managing real time. And I will close by highlighting with some AORN resources that we have available to help you connect with nurses and decision makers during the crisis. A recording of this town hall will be posted on the partner page of the AORN.org website on Monday. So to begin this town hall, I'd like to introduce Linda Groh, our CEO and Executive Director, who will speak on AORN's response to the COVID crisis. Linda?
Thank you, Maureen, and welcome everyone. I want to first of all cover what is going on with this current phase. It really is managing through the COVID-19 crisis and providing the resources that our members need. This is a very disruptive time in what's going on in healthcare. And I don't need to tell you the ramifications of what's been happening. We have, as Maureen will tell you later, we have put together a number of resources that are updated daily from other organizations that we're working with. For example, the FDA and CDC, when they were looking at how could we sterilize the N95s, they came to us to get some input in it, into the processes. We also worked with the Joint Commission on looking at what was important in terms of backing off of when they were still doing their surveys. They now have decided they're not going to do surveys until perhaps June 1st. However, that is a moving target. We've worked with critical care education, which is a very important piece because many of the operating room staff have been moved into critical care or into the emergency room to assist with care in those areas. Critical care put together a great online education for care of the patient with ventilators. We have held clinical town halls, and we have had an incredible number of people attending those. Those have been recorded, and on YouTube, we've had over 5,000 views of those town halls. We also have our COVID-19 support pages have had a 61% increase over the same period last year. In 2020, thus far to April 9th, we've had 3.2 million views, as opposed to in 2019, that same time frame at 2 million. So we can certainly say that managing through the COVID-19 crisis is part of what AORN has been doing to support surgical opportunities and helping them get through this terrific time that we're finding ourselves in. Next slide. And we've had great feedback from our members. Here's 3 different ones that have identified that they are very appreciative of everything that we are doing for the frontline healthcare workers and how proactive we are being. And everyone is so impressed with the early decisive responses that we put out. And as I said, many organizations have come to us for additional information. So when are we going to know when it's time to reopen the nation? There actually is a report that was done from the American Enterprise Institute. Dr. Gottlieb was the person who is the main author. And this was released this week, and it is one of the guideposts that we can expect that the White House is using, as well as FEMA. There needs to be sustained reduction in the cases in the city and state for at least 14 days. Hospitals in the state must be able to identify and safely treat all the patients that require hospitalization without resorting to crisis standards of care. The state needs to be able to at least test everyone who has symptoms, and the state must be able to conduct monitoring of confirmed cases and contacts. This document is available online in its full entirety if you're interested in seeing it. Again, it's from the American Enterprise Institute. So what is phase 2 going to mean? Well, phase 2 for the operating rooms is going to be very chaotic unless we take control of it. And AORN did do that. We convened a panel and a group, including the American College of Surgeons, the Society of Anesthesia, and the American Hospital Association to talk about the issues that are going to be confronting us as we move forward. We had our second meeting this morning, and we have a document that we are moving forward on. And this document will provide the government and other agencies the way to go forward with opening surgery. Included in this area, of course, is the operating rooms have been turned over to ICUs, and now we need to turn them back into operating rooms. Negative pressure needs to become positive pressure. supply availability. And today on our call with the group, AORN has taken one of the leads in looking at managing the supply availability. We are concerned that surgery may start in one part of the country while we're still treating COVID-19 patients in another part, and the supplies for medical surgical as well as the PPE will not be able to keep up with the requests. Staffing is an issue. We know that once the decision is made to go forward with staffing, there's going to be some facilities that are going to want to look at 6 and 7 day surgeries, and is that appropriate? We're already beginning to hear about PTSD in the reference to the staff in the operating and recovery rooms. Surgery scheduling, how are we going to decide which surgery should be top on the list? There are some models that have been developed for this, but there are instances where those models are being challenged. Where should cancer patients fit into that? And what are the regulatory issues going to be involved in getting back into surgery and getting startup? What about those checklists that we use, the timeout? And most important is the checking and the testing of both the staff as well as patients. Is it only COVID-19 negative patients that we should be doing surgery on? And should every patient be tested as well as every staff member, and how frequently? These are some of the issues that we will be dealing with and are starting to deal with to create this pathway going forward to resemble some sort of continuity and consistency by developing guidelines as well as policy statements that we will be able to implement throughout the institutions in this country. So thank you for joining us today. This is a very important partnership that we need to make sure that we have going forward as we resume surgery. Next slide. Now I'm going to turn it over to Judy Pins, who will be talking about the survey that was done by AORN.
All right. Thank you, Linda. Good afternoon, everyone. As Linda said, my name is Judy Pins. And over the next 15 minutes, I would like to be able to update you on information that we are receiving from our front lines of perioperative nursing. So if you look here at the next slide, you'll see that I'm taking my highlights. It's coming from, we did a survey, and the survey was done within the last 2 weeks. It was, we had a great response. 1,200 perioperative nurses responded to the survey. We also have had a number of town halls. So we have, as Linda said, 5,000 views. So we have good information there. And then this week, I had the opportunity to interview for quite some time 4 different vice presidents of perioperative services in some of the hot spots throughout the country. And the conversation focused a lot on what's happening with elective surgery, the cancellations, as Linda said, what's happening, how are they planning to ramp up, when and how? What are some of the workforce issues they're encountering? What are some of the PPE challenges that they have? And then how can we, those of us who work in industry, help? So as I said, the survey was administered within the last 2 weeks, and we had about 1,200 members and respond. We also, as I said, had the virtual outreach and then the one-on-one interviews that I have been doing. So let me just, I'm calling them case studies, but let me start by framing one of the results, one of the slides that we had from our survey. When we asked the group, are they canceling cases? You can see here that almost 85% of the respondents did say that, yes, we are in fact have canceled our cases. My guess is that from the anecdotal information I'm receiving, that number is much higher now than 85%. Remember, this was within the last 2 weeks. And that the nurses, yes, they are being reallocated to other units, and that they are also being put on furlough. We also asked managers, how likely are they to reallocate their staff? And you can see about 60% said yes, highly likely, and another 15% somewhat likely. So I wanted to validate that data when I talked with our VPs of surgery this week. So one of the hospitals that I went to or talked with is in Tennessee. It's a very large hospital. They have 55 operating rooms. They do somewhere between 120 and 135 cases every day. The VP told me that our hardest hit areas and specialties are joints, spine, plastic, and bariatric surgery, as well as GYN. And those doctors, they said, are just very, very anxious to get back in there and be doing surgery, and that for most of them, they are like the rest of us, kind of homebound during this time. That today, this hospital is only doing somewhere between 10 and 14 emergencies. And you can see there, I've listed what those emergencies are. Then I talked to a hospital in Michigan. Michigan, this is a very, very large system. They have between 185 and 220 cases every day. 90% of those cases have canceled. 18 to 20 emergencies is what the VP told me. Mostly trauma, vascular, and even a few appendectomies and gallbladders. And the person really was stressing. You can just imagine we have 16 rooms that are totally dedicated to joints. Those rooms are busy all day doing total hips, total knees, etc. And they have been sitting empty every day now for several weeks. Michigan, Maryland. I talked to a hospital in Maryland. They are, one of the top hospitals in the nation. They do over 100 cases every day. At this facility, they said they were doing somewhere between 30 and 40 cases each day, which was a little higher than what I had heard on some of the other interviews. But they did say because of the type of hospital they are and the critical nature of their patients, that they probably do have a little bit higher schedule they're doing every day, but that it's determined by a panel of physicians with lots of input from perioperative leadership. And the cases that they're doing are very similar to the other 3 states: cardiac, thoracic, vascular, and brain tumors. I think it's fair to say that every place I talked with, they do have a system in place that is led by physicians and nurses and administration on who they're going to operate on that day. California. This is a 4-hospital system. They do between 140 and 150 cases a day, and all of their electives have canceled. So I think you're seeing the data, just the anecdotal data does support what we saw in the survey. I thought it was interesting here, this hospital said they've had excellent support from their surgeons, except for early on in one location where a competitor was still doing elective surgeries. There were some issues, but those got resolved very quickly. And that, again, like the other hospitals, they have a committee that meets early each day and they approve the emergency schedule. Now, many of these hospitals, as you can imagine, if they're doing this kind of case volume, they have staff that ranged from somewhere around 450 to as high as 750 people. So a lot of staff is being impacted here with these canceled surgeries. On our survey, we asked people, what are the activities that are taking up most of your time? And you can see here from my graph that the #1 thing was screening and restrictions, and probably developing a lot of policies around screening. I know, we have an employee at our place that cannot visit her husband. He's in the hospital this week, but no visitors are allowed. And we're seeing that at many, many of the hospitals that I just shared. Staff, restrictions and screening of staff as well as patients. They said they're also spending a large amount of time either converting, as Linda mentioned earlier, rooms into ICUs or designating areas specifically for the COVID-19 patient. In all 4 of my interviews, none of them had converted their actual operating rooms into ICU beds, but 2 of the 4 had converted their PACU units, their recovery rooms, if you will, into ICU facilities. So that is definitely happening. And we are seeing in some hospitals, they're converting their ORs in a different way. Some places are actually designating operating rooms where they go in and intubate the patient in that room that they designated, and then they transfer them to another operating room where they do the surgery. And I'll talk a little bit later about why they do that. You know, obviously they were working on cancellations of elective surgery, and then supply conservation. We listen to the news every night and we know how important this is, but they are definitely spending time trying to find that PPE, and lots of stories about at each of the facilities about some of the challenges. And they are educating and cross-training their staff. The perioperative team has a lot of expertise in PPE and donning and doffing of attire, but when they go out to the units, they find out that there is not the same level of knowledge. So some of the staff is being redeployed just to help people understand how to put on and take off the PPE. And there is a renewed focus, as you can imagine, on cleaning with the COVID-19, and the perioperative staff is helping with that as well. So those were the activities most often mentioned in the survey. I asked them, and this of course is just in the last 2 days, what is your top priority this week? And these were the top responses: keeping patients, staff, and doctors safe. Most important, I think everybody had that at the top of their list. Secondly is creating ICU capacity. And I talked about how 2 of the 4 facilities had already turned their PACU units into ICU units. And then the third was just appropriate use of PPE. It's also getting the PPE, but once they get it, are people using it appropriately, and what do the policies and procedures say? And they also talked that oftentimes there's conflicting data coming from different associations on what they should be using and when. If I'm a nurse and I'm in ICU, should I be wearing an N95? Should I be wearing a surgical mask and then later changing to an N95? You know, one hospital told me that they are absolutely out of isolation gowns. And they have one isolation gown they hang on a hook outside the ICU patient's room. If the nurse goes in, she wears the isolation gown. When she comes out, let's say a phlebotomist goes in to draw blood, she puts on the same gown, wipes it down when she's finished, and they use that same gown all day long. So we really do hear some very severe challenges about the supplies, as well as what's appropriate and what's inappropriate. Again, the operating room team is being redeployed as observers, and they've been sent to the units and to different floors to make sure that, as observers, that people are wearing the proper attire and they're putting it on and off correctly. And then the last thing that they're doing that's taking an awful lot of their time is redeploying staff. All the hospitals have command centers. All of them have staffing being done in a central location. And imagine just trying to redeploy some of these staffs as large as 400 and 500 people every day. In the survey, we asked OR leaders and nurses, what do you need the help with right now? And these were the top 5 responses. Help us manage supplies during this pandemic. Help us with environmental cleaning. And by that, they're asking for what really should we be doing as far as cleaning? And I will say every hospital seems to have put environmental cleaning on steroids. There's a lot of emphasis, as you can imagine, on that right now. How do we keep ourselves and our loved ones safe? How do we receive and triage patients? And then lastly, how do we convert those operating rooms and PACUs into ICU units? We also had quite a few open-ended comments. You can see here we had over 280 people that wrote in comments, and some of the key themes there were, we need help on anything you can do to help us with COVID-19, any topics we're hungry for right now. You know, managing supplies and equipment is always up there and probably the top 3 issues. PPE, education, use, standards, different leadership topics as far as how are we managing the crisis, and then ventilation. And I'll talk in more detail about ventilation here in a minute. Compensation. I was curious to learn what is happening to the average perioperative employee, whether it's a surgical tech, a nurse, a perfusionist, you know, what's happening. And we've seen everything from from, I'd say all 4 of the hospitals I talked to in the last 2 days stressed that their hospitals have just been incredible. They're doing everything they can to help us prevent having to lay off staff. So I think that was the most common response. One hospital out of the 4 talked about pandemic pay. They actually have their staff at home, but they're paying them 70% of their salaries, and they refer to that as pandemic pay. Lots of responses from the other 3 about employees are allowed to use their PTO, paid time off, and they can even borrow. So they can go to the bank of PTO and take maybe 40 or 80 hours of pay, knowing that when they get back to work, they will put that back and pay that back into the bank. And then, we do hear too of hospitals in the interviews. I heard about hospitals across the street or down the road that actually have laid off their staff, and they're not getting any pay, but they do get, are providing at least 3 months of healthcare insurance to those people. So asking the question this week, what are you thinking as far as ramping back up? And our most common response was, one person said May 1st, another person said May 11th, the other 2 said early May, but everyone said it's so fluid and that we really will decide probably every 2 to 3 weeks what our plan is as far as ramping back up. But they all have efforts going on thinking about how are they going to approach ramp up. So these were the questions that they were asking internally. Will the backlog of patients even have insurance? Will the patients want to delay or postpone their surgery just due to fear of coming into the hospital and possibly picking up the disease that they did not have? How will the remaining backlog get prioritized? What is the internal process and guiding principles for deciding which patients get scheduled first? I think that is going to be very, very challenging and very interesting. Will the hospital want to open rooms on Saturdays and Sundays with an already exhausted staff? And the cases currently on hold ranged from 3,000 cases to, in one system, they said they have already 7,000 patients backlogged. So there is going to be a huge pent-up demand for elective surgery once we get through this crisis. And then this came up in every single interview. Will we have PPE and products to do elective cases? It's going to depend on if we can even get the products for us. And that's where I think all of us that work in industry can really help. There's a real call for help here. I mentioned ventilation, and I want to talk about high-risk procedures. One of the things that we're learning is that intubation and extubation are really high-risk moments for the staff to be contaminated. So I think just about everybody I talked to has created or had a vendor create these Lucie boxes that are clear and transparent, and they put those over the patient's head and neck and chest. And then the anesthesiologist actually intubates the patient, putting his or her hands through that box. So that seemed to be something that they innovated on very quickly and that they're putting in place. Also, we heard in some of the hospitals, they have intubation teams, an anesthesiologist or a CRNA who actually is they're the only ones that are allowed, a subgroup, if you will, of experts, and they're the only ones that are allowed to intubate. In one hospital, they do all of their intubations now in the intensive care unit, and then they transfer the patient to surgery because they feel that that room's already contaminated, and so that's how they're handling it. In another hospital, they've set aside 5 or 6 rooms, and in those OR rooms, that's what they use to intubate, and then they transfer the patient into a regular operating room to do the case. Some people said that after they intubate, they have a policy that said, or I'm sorry, after they do the surgery, they have a policy that says we have to wait 30 minutes before we can clean the room. So the patient has to be extubated and out of the room and wait 30 minutes before they can begin their cleaning protocol. Another person told me we have a protocol that says the team waits outside of the OR, anesthesia does the intubation, and then they wait 6 to 7 minutes, and then the team is allowed to come in to do the procedure. So I would say that anesthesia staff are now heavily involved in all of the protocols and the compliance issues throughout the entire hospital. Of course, anybody who needs a trach or trach care is also a high-risk procedure for the staff. And then, you know, I did ask the question, are you seeing resignation of nurses or surgical techs? They're just like, I can't take this. I don't want to work in this environment, and they're quitting. And the answer every place was no. Although at one hospital, they did say some of their respiratory procedures, you know, are high risk, and they are seeing a higher number of resignations from people that work in the respiratory therapy area. So how can we help those of us that work in industry? Please get us product, especially PPE. No surprise there. Help us determine our capacity based on supplies. So I think this is really important as they ramp up. They're looking for us in industry to help them. Can we match the supplies with what they're anticipating for their demand? Many comments on how all of you have been heroes in this battle. They see the industry team as partners. And I did hear some very nice stories about how the sales reps have gone above and beyond to help people find products. In one hospital, they don't have negative pressure rooms, which is important. So they've been doing some cases in these very small bronchoscopy rooms. They're the only rooms at that hospital that have negative pressure. And they didn't have surgical lights. And they said the rep was just great, went and found us lights, got them here, installed them, etc. And just, I'll say this here, I did ask people, have you had your staff infected and how much? And of course, a lot of people do not want to release that data, but we did have one customer that said we've had 3 cases. One was a industry rep, one was a pediatric surgeon, and one was one of our nurses. And then lastly, they're saying we can help by providing education. You know, there are a lot of nurses, doctors, techs at home, and this is a great time for them to take continuing ed and to get their CEs. So, you know, we asked that because we do a lot of education, and we wanted to make sure, is this even a good time to be providing it? And we did hear, yes, it's important right now. So I'll just conclude my comments with saying it was very humbling to talk to the leaders on the front lines. You really do walk away with so impressed with their teams. They said their teams are showing tremendous cooperation, support, the teamwork that is occurring between the physicians, the nurses, the ancillary staff. They said it's really quite heartwarming. Very few resignations, as I said, and instead they see an attitude every place with the caregivers of let's do whatever it takes. And they did say that people are showing incredible stamina and incredible dedication. And I know that's true for you, those of you on the call today. The same is happening in industry. So let me just say thank you. And Maureen, I'm going to turn it now back over to you.
Thank you, Judy. Thanks for presenting the view of nurses and leaders from across the U.S. In addition to having a broad view, we thought it would be interesting to hear from a nurse leader who's living through managing a team in a coronavirus hotspot. Here to share the approach for managing COVID and some real-time lessons learned is Deb Ebert from Memorial Care Health System in the greater LA area. Deb?
Yes, thank you, Maureen, and good morning, everyone. Thank you for your time today in joining us. I have been asked to just provide a snapshot of what life is like within our health system over the past couple of months. Want to first thank AORN for their rapid response to support our nurses. It's been very impressive, and we feel very supported by how quickly they've been able to provide us with information, have reached out to us on every level. So I want to express our gratitude for that. And also, I want to echo Judy's comments about our industry partners. We have also experienced it in every one of our facilities that our industry partners have reached out to see what they could provide to us to help keep us safe. So we're very appreciative of that and the time today. So our journey here, we have holdings within the Los Angeles and Orange counties in Southern California. And if you are tracking with the Johns Hopkins map on an hourly basis, as some of us are, we started with putting together our administrative response here at corporate back around mid-February. When we first started to meet and set up our central command center, we wanted to establish some governing principles to guide our decisions, being that it's very sobering. We're living in an unprecedented time. And this is coming from a nurse who's managed through multiple hurricanes and third world country medical missions. And honestly, I've never seen anything quite like this before. So we were really getting together as a leadership team. How are we going to manage and how are we going to lead our teams through this? So our number one principle was, and our top priority continues to be, to protect our staff and our physicians. If we are not well, we cannot continue to provide service to our community. So that was overarching number one. Of all of them, I think the second one that has been most valuable. These are stressful times, and for some of us, this is my 18th straight day, who are trying to provide the support that our teams deserve. We always want to assume good intentions because this has been quite a collaborative effort. I think that our aim has been, again, as you can see, we want to create the safest environment for our employees and physicians, allowing them to be safe, feel safe, and we're also trying to tap down as much of the fear of the unknown that we're feeling. And we also are an organization that focuses on wellness. We're in Southern California, so we are trying to do everything that we can with our wellness division to keep our staff healthy mentally, providing a lot of appreciation to them. As we set up our command center, if you go to the next slide, please, Maureen. I won't dwell a lot into the granular pieces of this, but we actually set up a central command here at our corporate office. And just to share with you some of the members that have been steering this, we actually have a call in the morning, we have a WebEx at the end of the day, and we've been doing this again since around mid-February. Next slide, please. We also have key work streams that we've developed, and I've listed these for you. It's been quite an undertaking, and of course this has evolved over the last couple of months as we've had to build everything out, with our surge plan being one of the later. TLC is our tender loving care. We have found that to be very important. We see evidence of that if you're on LinkedIn, on many of the social media pages, with how everyone is reaching out to our teams to provide support. So these are some of the key work streams that we have that have been able to help lead us through this. Next slide, please. Again, these are, we also have at each of our hospitals, we set up campus level command centers. Some of the key members that are running those are a little bit more chaotic, I would say. Again, there's a lot more members, work streams associated with them. We have calls each day. Some of us have been deployed to go and support. This week I've been in Scrubs all week, and I've been at the Long Beach campus. We are just about midway in our surge level in the Los Angeles County, and so we are trying to augment our support there. Next slide, please. When we wanted to start figuring out some of our initial tools, how are we going to manage? Where did we start? Before we canceled our elective cases, we knew that we needed to establish some standardized screening tools for our pre-op patients. So we pretty much were following CDC guidelines, and this again evolved as our situation was fluid. So that was one of the tools that we used initially. We also at some point had to look at following our Surgeon General's recommendations, and there were our governor in California again made some changes. So we met with our surgeons, our proceduralists, and we discussed a case scheduling triage tool. So we did develop a tool that we could use that would allow us to take care of those patients that were urgent and emergent, so that we would not be delaying those cases. And then those that could be postponed for 4 to 6 weeks without any negative outcomes. Those we have asked to hold. We've been meeting with those surgeons and proceduralists on a weekly basis, mostly just to keep them calm, to let them know we are assessing it on a daily basis. And to Linda's comment earlier, everyone is looking for that magic date for when we will be able to resume what we hope will be at some point life pre-COVID will be more normal operations. We have had to redeploy staff with a lot of training in Orange County. For us, that's not been as much of an issue. Those are not, those hospitals do not have a bargaining unit. In Los Angeles, that is a union, those are union hospitals. So that tends to complicate things a bit when we're moving people and moving shifts around as far as the staffing goes that Judy had mentioned earlier. And of course, we've had to make a lot of other operational changes. And I think Judy touched on those and covered them really well with how we've had to take some of our operating rooms and convert those and repurpose those. Next slide, please. So we have been knee-deep for the last couple of months in COVID-19. Everything else, of course, all other projects, everything else has ceased, and our entire health system is totally committed and focused on nothing except for, right now, I think what we would call the war zone that we have, really focusing on the safety. And I think our teams have so much at the campus level, they're really just focusing on survival mode. So about a couple weeks ago, senior leaders, I pulled my exec directors and directors together, and we started to look at a recovery plan. We want to move from the intra-op piece into the recovery room. So we have, working with our COO for the health system, we're putting together a work group or a task force to start to work on what our recovery plan is going to look like. So as we're able to start to resume normal operations, or what that's going to look like, we'll have a plan in place and we'll be prepared. So as you can see, some of the work streams that we are considering and some of the methodology is, what do we do with our blocks for those of us that have blocks? We spoke earlier about extended days and hours. Again, if you're in a non-union hospital, that's an option. Sometimes with a union, it's not. How are we going to prioritize our cases? Or we are going to have to develop a similar tool to what we did when we started to postpone our elective cases. I'll come back to supply chain in just a moment. Staffing is another one. Judy had mentioned about the changes that we're experiencing. And I think, and the fear. So are we going to lose staff because of the situation? Are we going to lose them because they're going to move to a different area? So there's a lot of concern in our organization now, and I think my colleagues as well, as what our staffing capability is going to be, particularly when we know that we have a shortage of peri-op nurses in general. Impact of COVID-19 on the future of anesthesia. I've been spending a lot of time the last few weeks with our anesthesiologists. They have really been very involved and engaged in this for obvious reasons. And I'm a little concerned about what the anesthesia practice is going to look like going forward. Our partnership with surgeons and schedulers, we do have some unique opportunities with some healthcare efficiency projects we have here that allows us to gain share, so to speak, legally with our doctors in California. So we can also partner with that group that our Senior VP for Innovation leads. So these are just some of the pieces of our plan moving forward. And again, we are just in our beginning phases. I want to talk a little bit about supply chain. The support, and I know that Judy mentioned this earlier, and I want to give kudos again to our materials management teams. In fact, they need a raise. They definitely need a raise when this is over with. The VP for materials management and strategic sourcing is in the office next to me as I speak, and I think he and his team have been working 24 hours a day. So right now, of course, we're focused on supplies for survival mode. But I asked him, as I'm planning this and I'm putting this team together, we really are going to have to sit down and understand what type of, how far reaching is our supply chain disruption, and how are we going to mitigate that? Because as I'm getting ready to work with the teams on a plan for how we're going to re-engage, obviously supply chain is going to be at the heart of it. So really looking forward to working with our industry partners in AORN to see how we can work together on that. Next slide, please. Okay, so just a brief summary of our journey. We started early with our disaster management plan. I think one of the reasons that we are in good shape, and we're so grateful that we, as Judy mentioned, some of our colleagues, their organizations are extremely low on supplies. Right now, we're holding our own. We are starting reprocessing, FDA-approved reprocessing programs. I think our governing principles have helped us through our journey. We have a team working on just combing through the review of evidence that comes out every day, CDC, AORN, ASA, as Judy had mentioned earlier. And I think that the communication system has to be the heart of the success, tapping down the fear in an unprecedented situation, having a good tiered structure, making sure that we're getting out to our community physicians and clinics that are part of our integrated health system. And then strong supportive teams. Again, as I mentioned, for the last few weeks, I've been in scrubs on the weekends, at nights. I think right now for leaders, and I'm going to share this with our leaders with AORN next week, visibility is everything, I think, right now. So that has been very much part of my mission lately. And I think the proactive recovery plan, that's my next focus. So, and I think in my weekly call with some of my colleagues around the country, we do get together once a week. Our Periop tribe, and we're all looking at that now, just as far as strategic planning. So really looking forward to partnering with industry and AORN on how we can move forward with that. Okay, so last slide that I have that wanted to share some of the major challenges, and I know Judy and I think we've covered a lot of these already. Supplies have been first and foremost, particularly PPE for safety. Storage, we are stockpiling when we can obtain product, and of course for us that's an issue. Some health systems not so much. Judy mentioned PPE knowledge base and skill set. I think for our opportunities for partnering with education post-COVID-19, I have a whole list of topics. And goes without saying, disruption in our revenue system. I can tell you that the CFOs are stalking me, wanting a date for when we're going to be able to re-engage. And then I think, as I mentioned earlier, the unrealized consequences on the future of perioperative of our ops and our workflow. I don't think anyone has a clear picture of what our future state will be. I just have confidence, and again, I want to thank our industry partners and AORN. I think together we'll be able to plan our way through this. So again, if there are any questions that you all would like to submit as far as our journey, I just wanted to share my journey with our organization. Also, just want to share one more thing. Wishing everyone good health. All of us, I think, are experiencing some personal losses. One of my colleagues here just lost her mother and father in the same week recently. Dealing with, and I think we're trying to manage through this crisis and dealing with the personal losses as well as the professional challenges. So thank you to everyone on the call for all that you're doing, and I will turn it back over to Maureen.
Thank you, Deb, and thanks to you and your team for all that you are doing on the front line. Excuse me. I think you know what I heard, one of your messages right now, visibility is everything from a leadership perspective. Also, I think for our industry partners, visibility and connection with our customers is really important for you. So I just wanted to share with you a couple of resources that we have that can help you connect with nurses and decision makers during the crisis. You go to the next slide, thank you. So this is our COVID website. It's an extensive clinical resource. It's updated twice a day, and our customers rely on it. After the AORN homepage, the coronavirus toolkit and FAQs are the most visited pages on our website. You heard Linda say traffic is up about 61% with almost 60,000 views. And when I say toolkit, that's our AORN language for a comprehensive set of resources for nurses and leaders. We are making this resource available to you and encourage you to place a link to the AORN COVID support pages from your company website. Some of you have already done this. For those that haven't, please take advantage of this resource available for you to use. We were all disappointed with the cancellation of the AORN Expo. It's such a great meeting for education, networking, and sharing information on new products. You heard today that many nurses have time and capacity for training, education, and I think at this time we're all looking for connections. And we can see that in the downloading and utilization of our resources and different courses. I'm excited to share information about our virtual Expo. With our virtual Expo, we are recreating the live Expo event for nurses virtually. We'll have an education hub with both live and recorded events and CEs, poster galleries, online Expo store, Expo hall, and more. We have a strong promotional plan with activities to keep it fun and entertaining for nurses, focused on driving traffic to the Expo and to sponsored booths. The Expo is available for free to all of our 42,000 AORN members, increasing your exposure potential. The Expo will go live on May 1st and run through July. This is a great opportunity to connect with customers, and there is still time to participate in Virtual Expo. We have sponsorship options available at many different levels. So if you're interested, please contact partner@aorn.org for more information on the Virtual Expo. Under the AORN Enterprise, we have additional services to help you stay relevant and connected during this time. Fiedler is our subsidiary that can create or repurpose education for you to offer to nurses. Outpatient Surgery Magazine is our tool to help you connect with hospital outpatient and ambulatory surgery center leaders, managers, nurses, educators, and infection control staff. In May, we are offering an infection control edition of the Outpatient Surgery Magazine, certainly a relevant and timely topic, and it is not too late to place an advertisement in this issue. In partnership with the AORN Foundation, AORN offers fall workshops and our Nurse Leadership Series, where we provide leadership and clinical practice guidelines. As COVID moves from crisis to recovery, AORN will play an important role in educating our customers and partners. If you're interested in discussing opportunities to participate in or sponsor a fall workshop or leadership course, please contact us at partner. We have a link at the end of this presentation. It's partner@aorn.org is our email address where we can provide more information. Not sure if many of you are aware of AORN's Integrity. It is our surgical EMR, and with a partnership with our exclusive analytics company called CareSyntax, customers can use their data to develop a surgery restart program. It will provide hospitals personalized playbooks based on their caseload and other factors as they restart or ramp up peri-op services. And finally, we have an industry policy council, a roundtable where medical device companies meet to share legislative and regulatory goals and gain policy insight of specific interest from AORN's government affairs team. At this point, I'd like to stop and ask you to respond to a brief poll. Please take a moment and answer the few questions on your screen. give you just another minute to respond. Great, thank you. Thank you, Carrie Lynn. Here are a slide that lists places that you can go to for more information. Again, here's the link to the website that you're free to link to your website. We will have a recording of this call posted on our website on Monday. And for any questions, requests, any clarification, please send an email to partner@aorn.org. And I think in summary, thank you for all you've done to help our mutual customers deliver care. Staying connected to OR nurses and leaders is important to move your business forward. And we are committed to being your partner during this time and in the post-recovery phase. And I wanted to end by sharing this note that we received from Hugo, who I think captures how we all feel. Gratitude for the work our caregivers do to provide comfort and care, and hopeful that they get a break soon. With all of us working together, I'm confident that they will get their well-deserved break. This town hall is concluded. Thank you for attending.